Hello everyone, welcome to Fostering Learner Engagement in a Virtual Environment. Both the chat and Q&A features will be available throughout this session, so please ask a question, make comments, and stay engaged. Thank you for joining us today and for attending this session. Now I'll turn it over to the moderator to introduce today's panelists.
Thank you again. So I'd like to introduce our co-moderators for this session, Alisa Nagler and Vince Loffredo. They are both directors of continuing professional development at the American College of Surgeons and the American Academy of Family Physicians, respectively. We also have two invited panelists with us, Erica Frank, who's a physician at the University of British Columbia and also works with NextGenU, and Janet Corral, PhD from University of Arizona. Thank you so much for being with us.
Hi, everybody. Great to be here. Thank you, Julia.
Thanks, Julia. Good morning, everyone. Good morning. Thank you for attending this session on fostering learner engagement in a virtual environment. We've all been successful in our pivot to virtual meetings and educational programs over the last 7 months. Most had to work very quickly to transition programs that had been face-to-face. And while we have not slowed down, I believe we're now a little bit less reactive and instead recognizing that there's some opportunities before us. We hope this session will encourage participants to reflect on what has worked well, what will persist over time, and how we can ensure that we are delivering quality educational content while helping to meet the social and emotional needs of our members in this virtual world. Some of this requires revisiting adult education theory and learning sciences, and we have to ask questions such as, have we engaged our learners? Have we truly engaged our learners? What virtual formats have been most impactful? Are we maximizing our use of technology? What other tools might exist that could help? How do we measure effectiveness or learner outcomes? How do we evaluate programs for purposes of improving them over time? Our panelists, like some of you, have been successfully using technology for education long before we were forced to have this conversation. We're delighted to have Drs. Janet Corral and Erica Frank, both of whom have engaged in digital education for most of their careers. They've implemented and studied virtual education programs and will share examples of their successful findings. We're going to start with Janet. Janet Corral, I've known for many years. She is newly at the University of Arizona College of Medicine and a true digital education innovator. She'll talk about the importance of applying the principles of learning science to ensure that we're impacting learning outcomes. We're delighted to have Janet here today. Thank you, Janet.
Thank you. Well, welcome everyone. And thank you for that kind introduction. What she didn't share, though, is that I'm a pedagogical troublemaker. So this presentation is actually about you. And to that extent, I am going to put you in the hot seat first. What is one thing that you want out of our time together today? When you respond in the chat, if you could also include your specialty society or your home institution, we'd appreciate getting to know you as an audience. I'll give you 1 minute to respond in the chat. I don't see any responses yet. Typically folks say, you know, I want to learn how to innovate. Thanks, Erica. Erica's looking to help colleagues successfully transition to a digital ed world. Thanks, Steve, for useful strategies that you're looking for. And Maureen, thank you for understanding the roles of who should be involved in learner engagement. And Michelle, the different modes of how to share education with our members. MJ Burns, thank you for acknowledging the needs for best practices. And Lisa, it's great to see you here from the AAMC, reminders of adult learning theory on virtual platforms. So that's a great way to get going today. I also always give the spoiler alert. So guess what? Here's the answer key. The real answer is we really need to move towards data-driven and evidence-based approaches. So we need to take that rich evidence base and our local data, bring them together to understand how are we really reaching our learners. I also want to bring about the idea that everything we knew before COVID is actually not what we're returning to. And I'm going to show you some data from our own experiences here at Arizona Tucson. And the last piece is I want to empower you to be intentional. The future is ours, and you are a gatekeeper to people's future practice excellence, as well as their own learning excellence. And so we need to model that in all that we do. So let's start by jumping into what is data-driven medical education. For many people, learning analytics is a new field, but it's basically taking the data of our learning and visualizing it so we can understand what's happening. So like I promised, I'm putting you in the hot seat. I'm actually going to ask you to be me. I started this job April 20th here at University of Arizona, Tucson. The school had already pivoted online. And it was my first day, and I was told, hey, the committee's meeting next week to decide, hey, when the students come back, what are they going to do? Are they going to be in person? Are they going to be online? And so my question to you that I want you to answer in the chat in the next 30 seconds is, would you bring the students back in person? There are no right or wrong answers here. There's a lot of right answers that we've seen across med schools in the AAMC. I'm using med schools so no one feels too much in the hot seat about CME. I love Lisa's response. Thank you, Lisa. Yes, there was phenomenal AAMC guidance on this issue, and it was wonderful to have that support as we made these decisions. I'll leave the chat open for another 10 seconds. It was very difficult in April. Yes, we weren't in person, but thinking ahead for July, that was definitely something we had to think through all the steps. Oh, I like the suggestion of established tiered learning objectives. Thank you, Devorin. So I'm going to bring us back together in 3, 2, 1. So this is the data that I had on hand. What you see in red is even pre-COVID. This is 2 years ago. We're students coming to lecture, and I want you to focus on that trough, people. Right when we were offering lecture at this med school, guess what? Nobody was coming. They were listening to podcasts of the year before. And then when the med school pivot online, which is the blue bars, those students also didn't come to our live Zoom lectures. So this wasn't about online learning. This was about something else. I engaged in a discussion with our faculty and our students that we really needed to shift the system. What we were experiencing was a square peg round hole situation. Even when we were offering Zoom sessions, it wasn't helping our students be the experts that they wanted to be, nor that what we espoused. So as we think about continuing medical education, we really want to focus on that top arrow here, which for all of you familiar with Anders Ericsson's work and all the theories on expertise, we need deliberate practice, which is opportunities to practice with very specific feedback and opportunities to practice again. And so in shifting that system, I told our faculty we need to bring together our local data and our evidence-based education. So here's an example of active learning. There's lots of examples of active learning, but we picked one flavor because we wanted to be really successful. We were also very intentional with our design. There's going to be so many times that students and our learners are going to be doing podcasts or very specifically designed recordings that are going to be short burst, high yield. So I'm talking 15 minutes, 20 minutes long, really focused on the core message. And when they come to our Zoom sessions, which only happen once or twice a day, we're going to be intentional. A short lecture, pose a question because we want the students to practice and apply. And then we want to look at their answers and give a mini lecture to correct their understanding. We want this to be high value, that the learners are using the expert in the moment to improve their behavior. So you may ask, did it make a difference? Guess what? They're showing up. There's no more trough. And so when we were intentional with our local data and the learning sciences, we were able to shift the system. This persists, this type of graph now persists. We're 3 courses in with the first years and 2 courses in with the second years. We're seeing the same behaviors. When we offer high value, the learners come. And so I'm going to also bring in that evidence-based design is going to matter long-term. This is a study that I did with a medical student at the University of Colorado, the institution that I just come from. We were trying to figure out at Colorado, why were students not coming to lecture? Folks, you might be CME, but the students that we have today are in many cases already your residents and your learners. And so if we don't understand how they understand education, we are going to be ships passing in the night. So I want you to look at this quote. The students were trying to maximize, and a key part of this quote in the maximization, let's go back. There's a high volume and a limited time. So we're looking for short burst stuff. The table below was one of the most humbling tables to me as an educator. And I'm going to start at the bottom. What the students are saying is that they didn't come to lecture because they got higher value out of third-party resources, which are the bottom two rows, and they got better value out of small group. Why? Time with the expert to answer their questions and get feedback. They didn't want my recording of my lecture as much as they wanted third-party resources in small group. That's Panopto. That's my recorded lecture. And here's the most humbling piece. They didn't want me in person, folks. I want to believe it's not because I smell or any other reasons like that, right? Like, you know, I thought I was giving some high value evidence-based education, but there's something else our learners want. So here's part of that answer key. The return on investment for them is their proof in learning. They don't want 50 minutes when they can get it in 15 and then do a bunch of practice questions. One of the key quotes from the study that the student at Colorado, Abigail Leibovitz, and I did was, look, if I can do these recordings from third-party resources and some practice questions, I have time to go for that run. So I have time for wellness that you tell me I need to do. I have time to make fresh food at night. If instead I come into lecture and I'm in these long half-day, full-day sessions, which CME also does, then we don't have time. We end up microwaving our food, right? And so think about the context that we're creating for people in a post-pandemic world. We're going to shift to a lot more virtual spaces. Let's be intentional about our virtual time together. Let's make learning visible. John Hattie out of New Zealand did a great meta-analysis, and he found of everything that impacts education, the third most powerful thing to impact learning outcomes is feedback in the moment. Very similar to the expertise literature. What you see here is some of my own work with virtual patients. All the different colored boxes are different sections of a virtual patient or online patient case. So some are histories, some are investigations, management, et cetera, et cetera. And what you see on the right is that gold path. In my PhD work, if we had enough physicians go through the case, we could develop what is that mostly ideal path of someone going through the case, and then showing them the permutations and variations and how their performance compared to that gold path with subsequent residents and students, right? We're helping people understand what is it that we want you to know and making their learning visible when they're off course. This is also done in med schools. I want to call out my excellent colleagues at Vanderbilt. They make competency visible. This is also one of the next keys for us. And when we focus on learning outcomes in the CME realm, we want a return on investment to be around how people are improving their own expertise and mastery. Can we start having more dashboards in our communities where we're making people's outcomes visible to them so they have that insight on where they need to go next? Just like Atul Gawande talks about having that coach in the OR for surgeons, we can do things across the disciplines by making competency visible. Again, I'm going to speak to evidence-based design, and here you'll note that I'm sneaking in virtual reality. In the future, post-COVID, and even during COVID, we need to leverage that VR gives us these tremendous environments online to explore, but we need to design it well. Most people are going to do what's on the right, which is just give people virtual reality and say, hey, spend 15 minutes with it and go for it. But what do we know from the learning sciences? You want to change learning outcomes, you need to do what's on the left. You need to give people a short burst in VR followed by some sort of quiz, question, way to, synthesize their knowledge and then give them short burst VR. This study by Richard Mayer and one of his colleagues is one of the first in VR that really shows how you impact learning outcomes in a big way. Most studies are still trying to compare VR to a tablet or VR to online learning. Those are the false studies. We really want to look at when you use learning design, does it impact, or evidence-based learning design, does it impact outcomes? It does. So the last piece that's important for all of us is that whether we realize it or not, many of our forms of education were missing the mark with our audiences, with our colleagues, but also not helping our colleagues become more sensitive to the wide group of patients that they practice with. And so you may wonder, is there racism in my own CME events? I'm going to be humble and point the needle at our own curriculum here at Tucson. We had a student and one of our faculty review our curriculum. guess what, folks? When it came to presenting cases, we had 144 statements where we were focusing diagnosis on ethnicity, and that is not what we need to do. I know that has been a practice in the past, but this is us. We are gatekeepers. We're here to shift the needle, right? And so it's not like there is a law that says, how do we answer the problem? There's answers in the literature. Here's a great checklist, and the citation is there in the bottom right corner. And yes, my slides are available through CMSS, where this checklist allows you to go through your cases and figure out how can you remove racism and make an inclusive case in continuing medical education training. Other pieces that are within our control is our content leadership. Where are we including articles and issues? Already, as we've reviewed our curriculum at the undergraduate level, we have found, and you'll see a short list of courses there, ways that we have integrated articles to do what? Have better discussions. And so, for example, biostats is an area where we continue to just focus on evidence-based medicine in our discussions. Have we ever thought to say, wow, the biostats have been used to oppress and suppress different populations at different points in time. How are we having these critical conversations also in our CME training? Another place within our control is our exams. If we continue to use multiple choice questions as a way to assess learners in continuing medical education and all across the continuum of medical education, we're going to keep reinforcing institutionalized racism. So here's a great study from our colleagues at UCSF. When they dropped the clerkship shelf exam weighting to less than 30%, the answer was everybody did better. More people got honors across the board, but importantly, the underrepresented in medicine students also did better. So folks, we need to also expand our lenses of assessment that we're using in CME. I also want to encourage you though that change is a process. I am by no means perfect at eliminating racism, and I am learning every day and I'm humbled every day. So I encourage you to join with me in how we're going to make our CME events truly about full mastery across all the cognitive and non-cognitive skills that we want our stakeholders to be great at. So I'm going to pause here and ask you to take 1 minute to write down one thing I've said. And this is personal for you. It doesn't need to go in the chat. What's one thing that you can take from everything I've said and bring it into your own practice? You have 1 minute. And 20 seconds left. And we'll come back together in 3, 2, 1. So at the beginning, I told you my spoiler alert. What we really need to do is focus on a data-driven world that's an evidence-based world, adopt new ideas with us and infuse them now so we're ready for a post-COVID world, and we need to be intentional in all that we do. I'm going to end with a story. I'm going to ask anybody to post in the chat what this dish is. Who makes this dish? These have been very popular across North America. Corning, excellent, excellent. Yes, I knew there'd be quick people to the punch here. So I'm telling you a story of Corning. About a decade ago, Corning was just not doing well in the market anymore. Their dishes don't break. Their dishes are wonderfully made. They met their mission as a company. And so their stock price was hovering around $5 a share. That's not great if you're the CEO. And really, how are you going to market more dishes to people because your product doesn't break? They needed to pivot. This is a story about us, folks. We need to pivot. We've done the same things for so long, just like Corning. We need to think in a new direction. So what did Corning do? I'm going to ask you in the chat if anybody knows the answer. What is their biggest market now? It's not dishes. It's not blenders, but good idea. I'm going to tell you that there's 8 billion of them that Corning does now, and almost every one of you today has one. Phone glass. Maureen, I wish I had a prize to give away to you. It's phone glass, folks. So guess what? Here's the answer. All these years later, and this is from the 2016 shareholder report, they are involved in 80 billion phones. In 2007, they were making 20 million in profits. In 2011, it was 700 million in profits. They pivoted. They understood the value of their product. They understood that they needed a new market, and they were able to achieve that. Folks, that's us. We know the value of what we've got, and we've got an answer key. It's the evidence base and our local data and eliminating racism, bringing it all together and using new modalities to reach our people and help our people get to expertise. I want to remind you and empower you today that you are a gatekeeper. It is your job to open the doors. This is one of my personal mottos. And so whatever learning you are designing, I want you to be thoughtful and think of that one thing you promised you would incorporate and check in with yourself 3 months from now, 6 months from now. Have you held that promise to yourself that you are opening the doors for others with better, higher quality education? Thank you so much for your time.
Janet, thanks so much. That was outstanding. I love the idea of ROI for learners, intentional use of technology, high value, and certainly opening the gate. So we'll have time for questions and additional discussion after Erica. Delighted that Dr. Erica Frank is here with us. She founded NextGenU, a portal to free accredited higher education, including medical school and residency training. She's going to talk about the need to incorporate warm and useful human interaction, customization, thorough assessment, and probably most important, competency-based education, as Janet alluded to, and we saw some conversation related to in the chat. Thank you, Erica, for being here.
Delighted to be with you. I've really enjoyed my interactions with CMSS ever since I started coming to American Medical Association meetings. I've been to 30 of those and representing American College of Preventive Medicine. So it's really wonderful to bring the knowledge and insights that I've had over the last few decades to this discussion. So thank you all for being here. And I look forward to your questions as I go along in the chat and then also at the end too. So I'm going to be mainly showing you a tool that I hope will be useful for you all. It is a competency-based tool and an evidence-based tool. And so it fulfills many of the principles that Janet talked about in her comments, and a face-to-face tool, but often done this way. Let me leap in though. So I invented NextGenU when I was on the faculty at Emory in 2001, before MOOCs existed. And we were then the first and still the only portal to free accredited higher education. So we have materials that are being used with learners around the world. In every country, we have registrants now, including, astonishingly, about 40% of US med schools are now using our resources. So that was, as a US med school trainee and faculty member, that was a source of great pride and happiness that we rated this well. And so this is important for you to know about, because it means that folks who are graduating now and finishing their residencies now, this is going to be their new normal. And so as you think prospectively, both about CME, but also about U and GME, this is going to be the new normal for a variety of reasons, which I'll show you, including efficiency. So we're available in over 100 languages. This is a slide that people tend to care about a bit. So These are characteristics that this kind of education shares with traditional universities, ones that we share with massive open online courses, and things that are unusual or even unique. People tend to particularly concentrate on this one, that we're for credit for free, but we're also competency-based. And this last piece that you cannot see, with an open research policy. So all of our educational outcomes get published on. We have, as I said, uniquely free both courses and now degrees. We started last May with University of the Incarnate Word in San Antonio, where we got Southern Association of Colleges and Schools accreditation for the MPH that they're offering for their medical students. And this is the world's first free degree, piloting it there. Next at New York Institute of Technology's College of Medicine, starting in January, and at several other venues globally. So that's available as a resource to you if your institution would be interested in offering either a full MPH or some subsets thereof to your populations, to your cohorts. Likewise, we have a med school in a box. This is just an outline, but we developed this with Stanford University of Central Florida and University of Toronto with a Macy grant, and all the way up to preventive medicine residencies. This is my specialty, and I'll tell you about that more in a moment. We have quite a raft of clinical courses. This one has been obviously particularly useful and was recently developed. I'll show you a little about this one. A lot of folks are using that for graduate medical education and for continuing medical education to provide something useful for folks that doesn't necessarily require patient interaction. This is the cohort of public health trainings that we have thus far, with more arriving daily, which I'll show you in a sec, and community health worker trainings. And these are our founding collaborators and funders, including CMSS member ACPM, which I'm a member of. That's my specialty society. And many other organizations that will be familiar to you. This one might not be the Annenberg Physician Training Program, but that's who we have our $16 million endowment through. Oh, and just to mention WHO, we're now on our 13th course, either for WHO or for CDC, that they've paid us to create and offer. And we're offering a health leadership course now with WHO that is a thing of beauty, and we're teaching it now to 50 public health leaders in the Caribbean with WHO. Would love to offer that to your cohorts. That health leadership course is really going to be, I think, something that could be especially useful for you all. So here's how we created. Again, as I mentioned earlier, and as Janet talked about, all of our trainings are competency-based, and we match them with learning resources, which I'll show you in a moment a little more about, and organize them into modules. This course, as I mentioned, I thought might be particularly useful for you all. In the 9 months since its launch, we have over 600 registrants for it, mostly in the US. A lot of US med schools have picked this up. And the course was developed in partnership with Oakland U Med School in Detroit and the Arnold Gold Foundation for Humanism. So these are a couple other trainings that might be somehow useful to you all or to your colleagues that I wanted to mention, and I'll give you a quick tour through them, talk a little about some of the evidence basis for this, and then I'll be done. So the MPH I already talked about. We have pre-health sciences trainings that are coming out shortly. The Med School in a Box that I mentioned that we developed with Stanford, University of Central Florida, and U of T. preventive medicine residency. I'll show you a little more about that. A student-facing Bachelor's of Science in Nursing, and a faculty-facing one as well with our partners at Nurses International. And now we're expanding all the way down to a K-12 curriculum. We've put in 4 grants for that in the last couple months. So in terms of disruption, as Janet talked about, this is a refutation of disaster capitalism, of the way in which a lot of online educational providers have stepped in with a capitalistic solution. I think there's a for us, by us solution, and I just want to show you a little more about that. So the MPH curriculum got all the core courses, got a whack of sample electives here, that some of which may be useful for y'all, particularly things like community-oriented primary care and knowledge translation, along with the health leadership course that I mentioned. Competency-based trainings. These are where our educational resources come from governments, peer-reviewed journals, universities, and medical specialty societies. And these are the places, as I mentioned, where we're already launched. These are the 9 courses that CDC has initially sponsored for us, all available to you all to use. Finishing our 11th course for them on non-communicable disease prevention, particularly cancer prevention. That'll be available soon as well. And I just want to pause here on the preventive medicine residency program. So this is, as I mentioned, my specialty. It's why we started with this. I ran the preventive medicine residency program at Emory for 12 years before I came to UBC. And it's a standard kind of PMR, 3-year-long training with a year of an internship in any discipline, and then a year for the MPH and for the practicum. So I want to close with just showing you a little about evaluations, both the kinds of evaluations that would be available to you to use with your learners, with your students of various types, and the evidence that this kind of training is efficacious. So students are able to evaluate all of the learning objects and activities, and they are evaluated with peer activities and mentored activities for all the skills-based competencies. These are done with peer and mentored activities just as they would be regularly. And then, of course, there are MCQs and a final exam. This is an opportunity for them to rate a resource, some instructions for creating MCQs as an exercise, a typical multiple choice question, our final exam translated into Arabic. These are the pieces of assessment security, and I'll turn to your questions in the chat in just a moment. I'm almost through here. In terms of assessment security, we offer pretty well state-of-the-art, what's available, again, for free. And these are some of our data. So from the Uniformed Services University of the Health Sciences in Bethesda, with senior medical students using our emergency medicine course, and the same cohort at Mizzou, senior med students finding identical knowledge acquisition. Same thing here in British Columbia with Simon Fraser University for our environmental health course, identical knowledge acquisition compared to traditionally trained students, and superior student satisfaction. This was in a flipped classroom setting. And then to close with some data from our study that we did with Grand Challenges in Kenya, with a strong preference for NextGenU trainings to traditional ones, with positive results in terms of trainee feedback on their outcomes, including even on stigma, positive qualitative outcomes as well. And my favorite piece of qualitative data, this couple at the bottom who came in for their 1-year follow-up, holding their baby, attributing it to the fact that their doc had taken this training about helping patients with substance use disorders. So I will stop there, and I will glance briefly, if you'd like, at the chat. And I see Vince's note, and I see Devoran's question, and I will stop screen sharing. And peer-reviewed journals are under significant stress. Okay. Yeah, so I'll give a 1-minute version to that, and then happy to follow up with any discussion on that at the end and subsequently. In terms of how to make this a sustainable business model, we work with professional societies all the time. We co-create materials. We have some of it available for free, and then the professional society, as professional societies do now and have done for decades, sell their value-added piece around it. So they're experts leading a webinar like this, just like we're in right now, right? They're peers being able to have interactions just with their own peers, just like we're in now. So basically making a classroom with a teacher for your members that's a value added for them, and that can be sold as well. Happy to return to that and to other questions later. Yeah.
Yeah. Well, thanks, Erica. Really appreciated that great presentation. That was really good. And as well with you, Janet, thank you so much for both your presentations. I think that has brought a lot of thought and discussion. I hope that's going to come here at the end. I'm not going to take up too much of the time. I just wanted to kind of talk a little bit about, you know, how we had introduced a lot of these concepts post pandemic or during the pandemic. Janet said, you know, pre-pandemic will not look the same as post-pandemic. And that is the exact thing I told my staff as we left the building. Having been part of 2 hurricane recoveries at the University of Texas Medical Branch down in Galveston, I knew from that experience that it takes a while to recover. And when you come back from that recovery, your office will not look the same as it did when you left. And I think that's very true for what's happening today. We all have been very good at certain things that we've been doing for a long time. In our case, it was a lot of the face-to-face on the ground education that we've been doing. And we've been wanting to pivot. As a matter of fact, we had scheduled our very first virtual course for May of this year, which in the end looked like it was just part of our flip over to a virtual environment, but we'd actually spent a year planning that. And we were trying to make this move towards a virtual experience, but really couldn't let our bread and butter go. We had to stick with what was generating the revenue. So, and I always tell our team, never let a good pandemic go to waste. We used that leverage of the pandemic to make our switch, to make that pivot. As we talk about, I think everybody had to move rather quickly. And in our case, we had been, taking our time, doing our due diligence and creating our ed plans and all of that. And on average, it would take us roughly about 4 to 6 weeks to create one ed plan for a course. We needed to pick up our game with this. And we made a quick shift and had very positive results. One of the assessment models that we use personally is our commitment to change. We ask all of our members after taking one of our courses, over the course of the next 3 months or so, we continue to survey them to find out if they've made a commitment, if they transitioned their practice at all in what they're doing. And prior to the COVID work that we were doing, our average commitment to change was about a 60 to 65% commitment to change. During the pandemic, the work that we pivoted towards brought it up to anywhere between 89 to 92%. And that change that we made was going to producing 5 CME activities a week. And we did that for probably about 4 months. And some of them were live that we turned into enduring products. So there were two of the 5 were those, but we had 3 live events a week that we could give for CME and give our members and learners an opportunity to engage with us, much like Janet talked about, for a short amount of time. We leveraged a product called StreamYard that allowed us to do social media on Twitter, YouTube, and Facebook Live. In doing that, we had that real snippet of 30-minute interaction with a faculty member talking about a specific piece of COVID or practice piece around the pandemic, and then had a Q&A, open Q&A, and it was ongoing. So we were able to create these communities of practice and become more agile in our work. In doing that, today we are looking, most recently, we were able to do 7 ed plans in 2 weeks. Really turning our team into a more agile team, reintroducing them to new ways of doing education in a virtual environment. We really wanted to hone our skills and become as good in a virtual environment as we were in our live environment on the ground. And so our national conference, which just ended last week, was a great example of how we were able to make that pivot really quick. Like most of you have already done and talked about yesterday, we recorded a lot of our information, not all of it, but a good portion of it. It allowed us to have that intentional virtual experience that Janet mentioned, where instead of having to focus so much on that lecture, as we saw in that curve diagram that Janet had, we were able to really focus on the questions and problem-based and case-based things that we were doing during our conference. And we saw an increase dramatically in participation, more so than we ever had. It was upwards of about a 70% to 80% increase in participation in our Q&As and throughout our whole presentations. So it's helping us form this continuous longitudinal engagement that we're trying to establish, that we were actually trying to establish last year with our learners, leveraging our national conference as kind of that point of start or stop in education, or ongoing, meaning that the education we could provide ahead of time led up to that national conference, and then information from the national conference was ongoing afterwards, and allowed us to be more holistic in our nature, not so clinical, but also get into some of our social justice conversations, some of our practice advancement conversations. It really allowed us to sustain a focus on specific areas throughout a period of time, whether that time was ongoing now or 3 months prior to up to, or 3 months afterwards. So we have a new curriculum now that's going to be ongoing, and why you see us talking about so many ed plans happening so rapidly. So that pre-recorded material, I think, is something that we have discussed about moving forward with, not in its entirety, but to try to leverage what we learned from that experience to try and have more of these snippet type educational experiences with our members and learners, where we can have that small group, short time to kind of talk some things out, give them a chance to go back, think about it, and either come back to another session with our faculty or get into the communities of practice that we're establishing in all these areas. Each year, we are bringing in new areas, topic areas, into our longitudinal engagement. This year, we had things like immunization, comorbidities, and COVID-19. Next year, we'll add women's health and health disparities and others into our longitudinal approach, but they'll always be ongoing. So as we introduce new, it's just building on top of what we have mainly because we can't do it all at once, and we want to be good at the ones that we start with at each period. So creating more of these environments around case-based and problem-based interactions is going to be part of our future, and also leveraging the social media and other aspects that we had not used in the past. We had the other part that it did by leveraging the social media and getting into this virtual environment is, as the American Academy of Family Physicians, we noticed that we were starting to getting an international audience. We started getting people from all across the globe participating in our chats, wanting more information and asking for how they could be part of some of the things that we're doing. So we're noticing that it has expanded our reach and is making us change how we think moving forward. And I'm sure a lot of you are having the same types of discussions and thoughts in your processes now. Our experience was a very positive one. We embraced the virtual change. As we had in our discussions yesterday, it can't be all virtual moving forward. I think we've used the terms hybrid and others of what our futures are going to look like. But I think that as we get into more of the virtual experience, we are going to see different ways to do it. Janet's slide on VR was a very appropriate one for us. We are working with a local university right now who built a whole center around virtual reality for the osteopathic students that they have. We are working with them on how to create similar type of short snippet VR type education, because we're trying to solve for those problems of those more tactile pieces that we had that we just couldn't do virtually. Though they're already building some of those simulations, and we're trying to figure out how we might build on that and create these smaller pieces for our continuous learners. And the other piece that I really want to emphasize that we are building on, that Janet mentioned as well, was this piece around building to the students. They are going to be our learners of the future. And a lot of our more seniored folks in our world have been very used to the CD-ROMs and the PowerPoint lectures and all of that. But those that are coming in our research is showing that they don't have that same zest for that type of technology. They're used to a lot of small group and simulation and small snippets of education, whether it's podcasts or lectures or all of that. The university I just came from, University of Kansas Medical Center, just built an entire building around that very curriculum. Team-based, small group, problem-based, simulation type learning. If our folks are coming out of their educational experience, residency experience with that type of experience, we have to be building on that now and be ready for them as they come into our societies. So it's just a holistic view at looking at this and how we might help build their clinical and their practice information. So with that, I'm going to open the floor to our question and answers. I know that we have some in the chat, but we have a Q&A button, and we're going to ask that moving forward. If you have questions for Janet and Erica, please use the Q&A button at the bottom. But to get us kicked off, I'm going to turn it over to Alisa, who has a question that she wants to pose to our panelists.
Thanks so much, Vince. That was, it sounds like you've had some really positive experiences in a difficult year. So related to that, Janet and Erica, you've been doing this for a long time and really successfully, and you showed us outcomes. Some of us are newer at this virtual education, and we talked yesterday, as Vince mentioned, that we know that there'll be some form of hybrid education going forward, that there's some real positive pieces and components to this virtual education. But we're guessing there are still times we really need to bring people together. So can you talk about when you feel like it's still critical to bring individuals together and have that human contact? Janet, do you want to start?
Absolutely. So that was a very intentional part of our design for reentry this year. We have in-person anatomy, ultrasound, and clinical skills. Because as everyone knows here, the art and science of healthcare is practiced largely in person, I think telemedicine really opens up new opportunities, and we need to think about CME very conscientiously in a telemedicine context, especially around emotional connections and empathy. I think that part of training can move to VR, but may also necessitate some in-person team building. Definitely with the procedural disciplines, this is where we still need in-person, right? And so if we think of that continuum of expertise and training, and we want people to practice, let's think about where we're giving the knowledge and where we're giving the doing, right? The knowing and then the doing and assessing the doing and giving feedback to folks. So our sim centers, again, virtual reality can fit on that continuum. There's also augmented reality. So University of Florida has some amazing VR for suturing, where in the VR goggles, you see all sorts of different patient cases, but you basically have a pig's foot in front of you, and the guidance in the system is helping you with your stitching. And so also our in-person discussions really help us with the non-cognitive skills. And I can't emphasize that enough, because that will be the real differentiator in the future. Information doubling time is happening so fast for our current learners and our current physicians and surgeons that we just really have to work on new models of encapsulating knowledge, but also working on the empathy and communication skills.
Thanks so much, Janet. Erica?
So I have a more radical answer than Janet does here. I think that when we're thinking about people, especially in rural and remote areas, when we're thinking about the personal and professional and climate costs of requiring travel, and when we're thinking about populations that don't necessarily have the financial resources domestically or elsewhere to do this kind of work in person, that we have an obligation to make this the new normal for them. And it's why I've been working on this for 20 years. That, and I'll give you the most extreme example of that I've participated in this, working with colleagues in Sudan. They have at that point, they had 3 family docs in Sudan. And they had just tried to expand teaching in person a cohort of 200 family docs in person. And the moment that they finished their training, they were all hired by Gulf states and left. So there clearly became a need to educate in much greater scaled fashion and folks who would stay put. And so we helped them create over 3,000 telementoring encounters between an expert, a mentor, a resident, and a patient. And it was face-to-face, and they got to look at where the residents put their hands. They didn't get to put their hands physically on the residents' hands, and that's sometimes nice to do when you're showing someone how to palpate a liver, let's say. But other than for those kind of subtleties, it fell into the category of so much better than nothing. And also something that improves every day with artificial intelligence and virtual reality. So I think my answer is rarely, if ever, is my answer for you, Alisa.
Janet, do you want to respond to that?
So one, I fully agree. As I've shared in the chat, I have colleagues in lower resource areas that have been phenomenal at training. I think we need to separate out the cognitive and the non-cognitive pieces from the actual procedural performance. So as we think of expertise, what I can never get past is our simulation is not amazing enough yet that we can fully certify someone based on a virtual experience. And I think this is going to be our next gen challenge for all of us. And let's be honest about med schools. What happened during the pandemic? We have students emailing med schools saying, well, I know the exam's at 9 a.m. in Tucson, but I'm back home with my parents. Like what's the time? So we're learning that our students have picked a distributed model, and the pandemic has helped us just acknowledge more transparently a reality that has always existed across many of the environments that Erica has raised. I want to bring up an example of one of the leading edge virtual reality pieces. And so you can do ACLS training in virtual reality. And the company doing this has partnered with a number of hospitals around the nation. And I have no stake in the company, no stake in these hospitals. But I'm going to leave it abstract and nameless for everyone here. But the hospitals in question are just using closets to train people in ACLS. And so if you're night shift, day shift, you go in and the closet has, a poster. The headset even coaches you, for us ladies with ponytails, how to put on the VR headset so you can do this successfully. And you do your 15 minutes of ACLS training. What's really interesting is you get all the data, and so does the Sim Center. So think of a continuum of expertise. If I do it and it says, you know what, Janet, you did a great job on ACLS, but you're, not that great at the pharmacology of it, that's the data that goes to me for feedback and the Sim Center. So when I show up to the Sim Center, now we're customizing where I need the tailored hands-on training with experts, but I can do all of the book work and the early practice in a virtual environment. And I think that's an immediate model that all of us can start adopting.
That's great. Thank you, Janet. It's a new way for us to be thinking, and you're certainly giving us some great ideas. I think Vince has some additional questions. Vince?
Yeah, sorry. Steve asked a question about, for us specifically, if we had medical writers and stuff on staff. We actually have learning strategists whose focus is to do needs assessment, gap analysis, and all that. And we leverage faculty to help us write a lot of that. They do assist with some of the writing, but we also leverage kind of a combination of our faculty as well. So hopefully that answers your question. Some of the other questions that we have, Erica, can you talk a little bit about some of the assessment tools that you've used with NextGen?
Yeah, so internally, we develop our own assessment tools based on the competencies, multiple choice questions, and deeper both qualitative and interactive exams, and then mentored and peer assessments. So all of the assessments are tied to competencies. So for example, for the emergency medicine training, we use the Clerkship Directors in Emergency Medicine guide for senior medical students and looked at their list of competencies. And, if it says you have to perform a venipuncture under the supervision of a mentor, then that's what you got to do, right, to get a certificate at the end. So using existing competencies and existing resources as well, in terms of the assessment. For our external assessment, we use the shelf exam that everyone uses for their assessment at the end of this clerkship, and did a historical comparator. So those are the two ways that I'd encourage people to work, to use historical comparators so you can see how you're doing compared to old modalities, and then when you're developing new assessment tools, to make sure they're tied to competencies and to make that really explicit for your learners. It builds on the finest aspects of studying for the test.
Thank you, Erica. I really appreciate that. I really want to appreciate all the comments today from my co-moderator, Alisa, Erica, and Janet. You guys did just a fantastic job today. A lot of information. I took copious notes as you were talking, as both of you were talking. It was just really, really good information. And to wrap up our session today, I'm going to turn it back over to Julia, who could just mention a little bit about just some housekeeping around where you can get the slides and the recordings and all of the session today. So I just want to thank our panelists again. And Julia?
Thank you, Vince, and thanks again to the panel. That was so interesting, and I hope to take many of the kernels from this presentation into future CMSS educational activities as well. So just a couple housekeeping items, as Vince mentioned. The slides, if they're shared by panelists, will be sent to all registered attendees from the meeting on Monday, November 2nd. All of the recordings will also be available within the virtual platform on that date and through the end of November. So if you missed another session for this one, feel free to check that out. And then finally, we're going into a 2-hour break from educational sessions, but we do have a dedicated exhibit time from 12:15 to 1:15 p.m. Eastern, and encourage you to visit all of our industry partners and thank them for their support. Thank you. Have a good one.